Hi, this is Brandy from Mana Health Partners, bringing you another video from our educational series. This one on history of present illness, requirements and how to write one. So today we're going to be talking about documentation requirements for evaluation and management, review of chief complaint, and the review of history present illness. So we go and utilize CMS, American Medical Association, in order to be reimbursed by Medicare. So we follow those standards of guidelines so that we can meet the medical necessity and the criteria needed for our documentation to reflect payment on reimbursement. And most insurances follow these same guidelines. So let's talk about evaluation and management first. I do want to emphasize that this video is included with a PowerPoint, and you will get a copy of the PowerPoint. It is available to you so that you can go over it, because I'm going to just highlight some things and then you can go over and review it afterwards. But why start at the bottom under how much money you're going to make or how you're going to bill when I specifically said we're going to focus on HPI? Well, you want to know what is required in your HPI to meet that requirement for the billing. So we're going to go over this pretty fast, and I'm just going to highlight a couple of things. So whether you're billing on medical decision making or on time, your evaluation and management services are the same. So those services may vary, like the nature and amount of work that the provider needs to do. However, there's a couple of key things that we need to focus on. First of all, the medical record should be complete and legible. You're thinking they're typed. Of course they're legible. Well, I want to emphasize that even though they're on the computer, we still have spelling errors, grammar errors, and while we can't be perfect and write everything 100%, if we use spell check, which is there and is the red squiggly line, make sure you click on that. Make sure you do spell check so your notes do look professional and that they are complete. Make sure that your documentation includes the reason for the encounter. That would be your chief complaint. What is that? The title of your story. And then any relevant history, physical exams, and or prior diagnostic test results. You're going to want your assessment, the clinical impression, or your diagnosis, and then your medical plan of care. So if you don't document your rationale for ordering diagnostic testing, it should be easily inferred. If you have a patient that's on thyroid medication, it's easily inferred that you'd want to do a TSH. Same thing with a congestive heart failure patient with 2+ edema and shortness of breath when laying down, then it is inferred that a proBNP would be applicable. Your past and present diagnosis should be accessible to you. Now, they automatically download from Point Click Care into our documentation system. But if they're not in Point Click Care, then they can't download into your documentation. How do you get them in Point Click Care? Well, let's take for an example an 80-pound woman that has protein calorie malnutrition, anorexia, adult failure to thrive, and weight loss. If those are not under the diagnosis in Point Click Care, take 30 seconds and add them to Point Click Care. So they'll be in the medical record and your documentation will be substantiating those diagnoses and how to address them or work on them. You should identify appropriate health risk factors. If they're at risk for falls, if they're at risk for weight loss, if they're at risk for infections, if they're at risk for wounds, if they're at risk for rehospitalization. All of those risk factors should be listed under your history of present illness. And then you're going to document the patient's progress, response to, and changes in treatment, and a revision of your diagnosis. So if you think they have coughing and wheezing and congestion, and then your final diagnosis is bronchitis, revise that diagnosis. If you thought that they had a cough and shortness of breath, and you find out that they had a chest x-ray, which is positive for pneumonia, then you're going to revise that diagnosis. And remember that documentation in the medical record should support and report the diagnosis and treatment codes that you report. So you're going to do your complete assessment and plan. Make sure that it's in perfect order. Anything that you've changed, added, deleted, discontinued, or worked up, those should be at the top. Those are your priorities. That's what you've spent your time on. And then the lesser would be lower on the bottom. Once you get that, then you get your ICD-10 code in the exact list. That's what you send to the billing, and that's how you get paid for it. Here's a URL that brings you right to CMS that talks about that. So the number and complexity of problems addressed. So even if you're not billing on medical decision making, let's just say you've decided to bill on time, you still have to have something that you're addressing. So it could be a bunch of symptoms that cluster around one diagnosis, or it could be each individual symptom that you're addressing. Comorbidities don't in and of themselves count unless we're utilizing them to support or substantiate a diagnosis. So if you've got a cough and you're a healthy patient, you could have a cough. If you have a cough and some shortness of breath and you have COPD, that comorbidity is going to play into the way you treat the patient with just the cough and the patient with cough and COPD. The final diagnosis does not in and of itself determine the complexity or risk factor. Again, cough with COPD versus cough. It doesn't reflect the risk, the extensity of what you're doing, or the signs and symptoms based on that. So a COVID patient with a cough and shortness of breath are going to be different from a cough patient that's generally healthy. Therefore, presenting symptoms that are likely to present highly comorbid condition may drive your medical decision making into a higher level. So all of that needs to be documented in your HPI. And the evaluation and management, as well as the treatment, must be consistent with the condition. And don't forget that if you've got multiple problems of a lower severity, like let's say you're reviewing a lab and they have hyponatremia, hypokalemia, chronic kidney disease, protein calorie malnutrition, and that's all just from one CMP that you're reviewing. Just because you've got a couple of little things doesn't mean that it doesn't add up to a 45-minute visit of ordering medications, lab follow-ups, and that they're at a higher risk related to that. Again, URL down here from the American Medical Association. So a problem addressed. Let's go down here to the bottom. A problem. So a problem could be a disease, a condition, an illness, an injury, a symptom. It could be a lot of different things that we're looking at. So don't think of the problem, I only addressed congestive heart failure. Problems can be multiple things, including the symptoms that the patient is experiencing. So we've talked about this during new hire orientation, that we're looking for problems that are evaluated and treated by us. So let's have, for an example, anything that is requiring further testing or treatment that we're going to take credit for. Anything that's saying another professional is managing without our assessment or without our help, we're not taking credit for that. We're not allowed to. You can address it, but just know that we don't get to take accountability for that. Same thing as sending a patient to another physician without evaluation of it. So if you've got a patient that's complained that he's had a sore knee for years and years, and you just sent him to the ortho. Is that really appropriate without evaluating? Well, evaluate the pain, evaluate when he's standing up versus laying down versus doing range of motion, evaluate swelling, redness. When you evaluate that, you're part of the team. And then you can refer them to ortho. But do you need to get an x-ray first for ortho to see? Do you need to get a SED rate to see about inflammation? But if you refer without an evaluation, you don't get to take credit for it. And if the patient is being co-managed by you and another physician. So let's say that you've got a patient, they've got breast cancer, and they're being followed by oncology. You are assisting with labs, you're assisting with medication management, you're assisting with follow-up, care and coordination between you and the oncologist, then absolutely take credit for that. Let's move into the chief complaint. Very short, very abrupt. Oh, that's how your chief complaint should be. It's clear and concise. We're looking at a symptom, we're looking at a problem, we're looking at a condition or a diagnosis if you know it. It can be in the patient's own words, upset stomach, aching joints, fatigue, cough, nausea, pain, very short and concise. It can also be, if you're doing your monthly and the patient doesn't have any new complaints, it could be you evaluating their diabetes, you evaluating their hypertension. So those could be your key phrases for your chief complaint as well. Don't use neutral language. Avoid long sentences here. This is the title of your story. You want to keep it short and brief. What is not acceptable is using something other than an ICD-10 code. Your chief complaint is your first assessment and plan. So don't put chronic management, don't put follow-up or labs reviewed, assumption of care without a diagnosis or an ICD-10 code, a skilled follow-up or medication review. What you're looking for here is something that is attached to an ICD-10 that you can list as the title of your story. The title of your story isn't chronic management. The title of your story is what that management is. Is it diabetes? Is it hypertension? Let's get into the beef of this. So history of present illness. So in 2021, per AMA, CMS, Medicare guidelines, they updated it. And they're saying that documentation must support medical necessity and a clinically appropriate HPI remains expected. Guidelines now emphasize the medical decision-making and or time determines the evaluation and management level. So you're going to document either based on time or MDM, one or the other, and that's what's going to affect our billing. How do we do that? By putting information in the history of present illness. So even though the history is not used as a scoring mechanism, you still have to put that clinically relevant and medically appropriate history under the HPI. So documentation expectations, even under the updated 2021 guidelines, an HPI should clearly describe the main reason for the visit, support the complexity or medical decision making that we're utilizing, and include relevant context for assessments and planning. So even though the HPI are not scored for coding, auditors still expect them to be present to support medical necessity and justify the visit. Interesting. An absence of a well-formed HPI can raise flags for downcoding or denial, especially in high-level visits. So it's not all about what we bill, it's about what we document and supports our billing. So if you don't know the format of what goes into an HPI, here's just a blank template that you can utilize. You can copy this from the PowerPoint that I send you, but if it looks familiar, it might be similar to old cards. We're all familiar with onset, location, duration, characteristics. This is what this template is referring to. So if we have an acute issue in our HPI, we're going to document symptoms. We're going to document what makes it better or worse. any other associated symptoms, usually related to that group, any history or background, and then any additional details. So here you can see an example of an acute problem HPI, and I'll let you read this on your own, but it goes through that old CARTS experience with documentation. Now, for a long-term patient, a lot of people just write patient in bed denies complaints of pain, doing well, no problems noted. What we're wanting to do is we're wanting to highlight stable, improving, or worsening of what? Of their chronic conditions. We're doing a long-term visit. You're going to want to document any medications or therapies or interventions and their effectiveness regarding medication response. Do you have to use the medications? No, you can write patient continues on antihypertensive medications, blood pressure log reviewed, blood pressures in the month of whatever have been normotensive except for one hypertensive episode noted on whatever date, which was rechecked and within normal limits. So make sure that if you're writing and clicking that snippet that said blood pressure log reviewed, therapy progress notes reviewed, blood glucose reviewed, that's great. That's good information. But that information needs to be documented under your HPI. And then make sure you're writing any symptoms or negatives. So everyone thinks negatives are bad, but what you want to do is highlight that there aren't any negatives. So let's say you're documenting on COPD or CHF. We're going to document shortness of breath. We're going to document O2 sats. We're going to document any bronchi. All of that information, we want negatives that says that not only did we notice the symptoms that they are having, but we're noticing the symptoms that they're not having. Here's an example of an HPI for a long-term care patient. You can read over this and just get a feel for it of how an HPI would be just based on a couple of diagnoses: hypertension, hyperlipidemia, and osteoarthritis. I know this was quick. I know this was fast. I really appreciate that. I appreciate your time. I appreciate your participation. I hope you found this information helpful and walked away with some valuable insights. Please don't hesitate to reach out. My email is here. My phone number is here. If you have any questions, if you want more information or details, I'd be more than happy to assist you. I will be attaching this PowerPoint so that everyone has it. I thank you for taking your time today to be with me. I know that your time is very valuable. Thank you for that. And thank you for being part of our team. If you have any questions, reach out. Have a great day.